My point. So let's talk about the lateral side, some background anatomy, different procedures. Understanding history is always important to understand how we go back in time and we kind of repeat it, and some outcomes, and I'll use a case as a presentation. So there's definitely an unrecognized injury to the lateral side. Just because you don't have a segundo doesn't mean you don't have lengthening of the lateral side. It's something that, if Addie's still here, looking at the lateral tibia and looking at some minor capsular avulsion injuries is very common. Realize that segundo, that lateral side injury that's obvious is really from a mega pivot, right? Your ACL, tears at 5 to 10 millimeters of translation. When you get 15, 20 millimeters of translation, that's when you clearly get a segundo. And that's really this concept of a mega pivot. Why do we care about this? Well, we know that ACL surgery isn't perfect, as we heard. And who are our failures? Well, younger patients, right? Younger patients fail everything more. Increased tibial slope, return to highly, pivoting sports. If you have a high Batten score, these are all equal high ACL failures. The anatomy of the lateral side is like the anatomy of the NPFL. It didn't happen overnight, no, but it's most likely that there is a thickening of this capsule. It is still debatable. One of my good friends, Volker Muschal and Freddie Fu, still don't really believe it's a discrete ligament, but clearly there's something there. Well, we do know that, the superficial IT band, and the deep IT band incorporate these Kaplan fibers concepts, and that posterior Kaplan fibers are also very critically important. So it's really more of a complex than really a discrete ligament, and understanding that is important of how we treat this. When you want to think of the biomechanics of the lateral side, you have to think of the primary stabilizer, the internal rotation and anterior translations, the ACL, but understand the secondary stabilizers, which is the IT band, the lateral meniscus, as I talked about this morning, right? We do everything we can to repair the lateral meniscus. If you remove the lateral meniscus, at time zero, your tibia will automatically spin an internal rotation. So even if you fix an ACL, you're fixing in a lengthened way. So that ACL will never stabilize that knee. And then ultimately you have your ALL and your anterolateral complex. So, here's an example of a segundo. This is, some people say this is a high incidence of ALL or lateral complex injury in all ACL tears. And if you look at some literature, it can show in chronic cases, we can see ALL injuries in upwards to 50 to 80% of patients. So why are we not doing more of these lateral procedures? Well, the issue is over-constraint, right? If you fix it, the lateral side with excessive external rotation, or you over-tension the graft, we could create lateral arthritis. We had a paper from HSS where we compared BTBs and lateral slings, and we had no difference in outcomes. This is historically, and we had a lot more arthritis. So the lateral sling was ultimately abandoned at HSS because we did BTBs. So where did this all start from? Well, it's all started in Lemaire in the early 60s, where he would take a sling of the IT band and tunnel it under the LCL and fix it on the femur. And then you have the Lucy graft, which was more of an A to P double bundle lateral sling procedure on the femoral side. And then the Ellison, which is a distal-based procedure and repairing it under the LCL to the tibia. So there are a lot of different procedures. There's also the McIntosh, and even in Andrew's IT band tenodesis. So this concept of lateral-sided surgery is not new, and although it was abandoned as we went to a stronger, more rigid grafts, we also now are getting more failures, and we want to look why. So when do I think of lateral-sided procedures? Well, it's with a grade 2 or grade 3, a high-grade pivot. It's called almost pivot speed, younger age, recurvatum, generalized high Batten scores or ligamentous laxity, returning to a pivoting sport, and even revision surgery. I will do a lateral procedure in a young athlete on a primary ACL. How do I do a Lemaire? It's a lateral incision, not this big. You don't need to touch the perineal nerve. The key trick is to use, don't go mid IT band. I go a little more posterior third. I create my femoral socket slightly anterior to the LCL. Ironically enough, some people actually claim it's more posterior, but that's what I do. I do a blind socket, and I use a button where I can tension it appropriately. Just like with the NPFL, you want this to work in extension and release in flexion, right? This is an extension stabilizer, not a flexion stabilizer. If it's tight in flexion, then you're going to over-constrain the knee. I use an anchor whenever I'm doing for open growth plates, and I use a C-arm to make sure I don't hit the physis. I think tensioning is really critical here. It's really hard to figure out what the right tension is. That's why I like an adjustable button. But you can certainly over-constrain this as well. So you have to be very careful. You want to make sure this looses in flexion. When I do an ALL, and I do an ALL kind of less and less, I'll use a 6 or 7 millimeter, piece of autograft or allograft. I'll do a blind socket and a femur with an adjustable button, and then this one does not go under the LCL. In terms of Outgood, the stability trial by Al Getgood really showed that with a hamstring graft, a Lemaire really helped their revision rate. It was superior to doing a primary hamstring. And in other kind of, in 4 to 500 out, Andy Williams' experience, he had a much lower graft failure rate with an LET, and he's doing now BTBs. So based off this work, everyone's now looking into Stability 2. Stability 2 is basically looking at quad and BTB and the role of an LAT, and do you still need a lateral slide procedure for primary ACLs? We're members at HSS of the Stability 2 trial. And this is a systemic review which basically shows that an LAT is probably protective to ultimate failure rates. What about ALL? Well, ALL has also been shown from Sonnery Cotette's work that an ALL can minimize complications and decrease your failure rate as well, similar to Stability 1. So quickly, this is just a case. This is a 35-year-old failed ACL. He had a BTB a while ago. He's got a 2+ Lachman, 2+ pivot, stable collaterals. You can see here tunnels. Maybe the tib is a little posterior, femur's not horrible, but what can I do to fix this one? Here, the lateral root was intact. So in this case, I did a quad tendon revision with a soft tissue anchor for a Lemaire. So despite renewed interest in the lateral side, the issues here are they're old and tried and true procedures. We need better long-term data with Stability 2. I think we need to get better understanding of the biomechanics of the lateral side and how to tension it properly. And I think the debate of ALL and LET is still out there, and we will get more information as we come. But I have a low threshold in my high failure athletes in those risk factors, as I pointed out, to use a Lemaire in those, even for primary ACLs. Thank you very much.